This program is brought to you by Emory University.
Well, good morning, everybody. Welcome to another edition of Friday Fellows Conference. Before we get started, just a quick reminder to the faculty to claim your CME credit for these. Our speaker this morning is Dr. John Larson. John, for those of you who haven't met him yet, is a first-year fellow in our clinical track at his medical school here at Emory. Then to the great North University of Michigan for his residency training, and then missed the mild winters and came back for his fellowship. And as you can see, he's going to talk to us about PFOs and stroke. So John, take it away.
Great. Thanks. Good morning, everyone. I indeed can't agree with the fact that right now I would be in probably month 3 of around freezing. So I am happy to be back in Atlanta. So with that, today I'm talking about the evaluation and treatment of patients with patent Forman Ovale and patients with CVA. I have no disclosures. So our learning objectives today: to understand the current guidelines when treating patients with cryptogenic strokes who are found to have PFOs by reviewing the primary data, to identify the high-risk anatomical features which are associated with higher recurrences of strokes in patients with PFOs, and to apply risk stratification tools such as the ROPE score when discussing PFO closure. So those are kind of the main 3 things. So as most of these do, this was kind of all brought about by a case that I saw back in Grady in July. This is Miss SH. She is a 60-year-old female with multiple comorbidities, including hypertension, diabetes, and a history of a provoked PE on Eliquis, who presents to an outside hospital after a fall, found to have a right hip fracture, and was taken to the OR on July 14th for surgery. She underwent anesthesia at about 4 o'clock, underwent her procedure uncomplicated, but upon awakening from anesthesia at 7 o'clock, she was found to be aphasic and hemiparetic on her right side. So a stroke code was activated, and she was brought to Grady via life flight for possible embolectomy. But when gathering routine labs and doing kind of routine studies before her neurointerventional procedure, she had a baseline EKG, which was notable for the following. So here we have the EKG here, and kind of, I won't walk through it all, but we are immediately drawn to these inferior leads and the ST elevations here. And then you can see kind of these reciprocal depressions in 1 and AVL. So obviously very, very concerning. And the STEMI was actually activated at this time. There was a discussion between the interventionalist and the neurointerventionalist with the decision that kind of, brain comes first. So she went to the neurointerventional lab and actually underwent a successful embolectomy procedure. And then she went to straight to the cath lab. So here are her films in the cath lab. I'll briefly show you. So let it load and kind of show you again. So that's her left side there. Really not a whole lot there. There were other films at different angles, but just kind of 2 shots there. So this is her right side instead. And you can kind of see, if you can see my mouse, that this comes down and then really just truncates right here. So then here's the same kind of view, but you can see the wire that's been crossing this. So in the procedure, given her kind of her history and everything, they did IVUS and really found that this was not really a plaque rupture event, and then there was no diffuse luminal irregularities, nothing calcific around there. So they actually just proceeded with an embolectomy as well. So this is her angiographic result after her embolectomy. And as you can see, kind of the return of this really large RCA really well with TIMI 3 flow, excuse me. So with a good angiographic result after her embolectomy. Notably, other things that were eventually found in her case. So this is her EKG post-cath with still having some of those minor elevations, but with significant improvement in her EKG. Also, things that were notable. So we wrote this up as a case, but so things that I really wanted to point out here. Here is her neurointerventional films. As you can see, pre and post intervention and embolectomy, pretty good result they had there. The cath films, like I already showed, and things that were notable. She also developed acute upper extremity limb ischemia. And this is a CT angiography of her clot, which was found that she embolized into her artery. And then here we also have a CTPE protocol with a pretty large bilateral saddle PE. So her case was complicated by multiple embolic phenomenon kind of going everywhere. So because of that, she underwent a workup. And here's her initial surface echo. I'll go through it once and then kind of pause it. So that's with the bubble study. You can kind of see it's subtle at the beginning, but once you look at it, so you can kind of see here that immediately after after the bubbles were injected, you could see them crossing over. So because of this, she underwent a TEE, and already without doing anything, you can see this pretty large PFO that's here. So this is it under Doppler. And then we have the bubble study. So as you can see, pretty positive there. So that was all of her workup. So now we found this PFO. She's had multiple embolic phenomenon. However, she has multiple risk factors. So we really underwent a discussion of what do we do about this? We thought it's likely provoked from her surgery, but should we close this kind of given the catastrophic sort of phenomenon that she underwent and had to get multiple procedures to correct? So with that, that was my first really experience with discussing PFO closure devices and PFO closure in comparison with other modalities of treatment, mostly medical. So with that, I decided, I should really learn and understand the guidelines and why they're there. So these are the current AHA-ASA, which is the American Stroke Association, 2021 guidelines on the prevention of stroke in patients with stroke and transient ischemic attack. As with all guidelines, there's kind of 10 take-home points, and take-home point 9 was specifically related to PFOs. So I'll kind of just read it here. There have been several studies evaluating secondary stroke prevention and prevention of PFO closure since the previous guidelines in 2014. It is now considered reasonable to percutaneously close PFOs in patients who meet each of the following criteria: age 18 to 60, non-lacunar stroke, no other identified cause, and high-risk PFO features. So if you kind of look, that's right here in this 2A guideline with a B level of evidence. The only actual level 1 guideline with a C evidence, which is kind of funny, is that the PFO closure decision should be made jointly by the patient, a cardiologist, and a neurologist. So we have a 2A recommendation for kind of this 4 specific criteria. And then moving away from that, we have a 2B recommendation for the same patients, but with non-high risk features. And then a 2B recommendation comparing the benefit of closure versus warfarin. They don't even actually specifically mention DOAC, but I'll kind of go through why anticoagulation is not discussed as thoroughly. And then at the end, after we talk about all the data and the risks and the features of that, we'll talk briefly about what the SCI Society actually recommends as they kind of do a more thorough dive and have some more formal recommendations there. So that's really talking about our the initial guidelines. So where does all this data come from? So I found a nice meta-analysis which compares all these things. So first is PFO closure versus antithrombotic or antiplatelet therapy. So this is with basically medical treatment of stroke alone versus PFO closure. And what we found, these nice 4 trials since 2017 are largely our drivers of this. Before these more recent trials and in the 2014 guidelines, essentially the majority of data was coming from the single closure 1 trial in 2012. And as you can see, in 2012, these 12 patient events versus 13 patient events. So really no difference. But since then, these more recent trials, we can see that these are beginning to kind of show favorably upon PFO closure. Although notably, looking in all of these trials, the data together and individually does not have statistical significance. But if we combine all data, including antithrombotic and antiplatelet therapy, kind of putting it together, then we see a statistically significant result with a hazard ratio of 0.17 to 0.79. I mean, a confidence interval, excuse me. So with these, we kind of see that this is likely a benefit. And notably, what I want to point out, and I'll point this out later, in both the Defense PFO trial, which was a trial that was specifically talking about high-risk features. Only the patients in Defense PFO, they all had high-risk PFOs. And then the more recent closed trial, in the closure device arm, there were actually 0 patients who had secondary, had safety events in the follow-up. As compared to 5 and 14. So even though, as in the Defense PFO trial, this cross is 1, you still are seeing, an absolute number of 0 in the PFO group. So here's kind of where they get the recommendation that in carefully selected patients that it will now become statistically significant for a benefit. Something that I also want to kind of mention in these is that those 2 first criteria, age 18 through 60 and non-lacunar strokes, was an inclusion criteria in every single one of these trials. So when we get older than 60 or you have lacunar strokes, we really have nothing but observational data to support or just have in the discussion whether or not these should be closed. So the data, the observational data, not surprisingly, it all does not favor PFO closure, but I thought it was just something to mention that the reason those 2 are selected are not because data says that it's not helpful, but because we have a lack of data and observational studies are saying it's likely not helpful. So this is kind of the largest, more recent trial that we use is the survival from the closed trial. So here on the left, we can see the PFO closure versus antiplatelet only. And once again, if you notice this red line right at the top is straight, they had no events over a 9-year follow-up. So pretty impressive there. And then when you compare this antiplatelet, you still only, it is only an 8% event rate over 9 years, but that is statistically significant here. And then in the same trial, they also had an anticoagulation group. So the closed trial was a 1-to-1-to-1 randomization to PFO closure device, antiplatelet, or oral anticoagulant. You can once again see that red line straight, but with the oral anticoagulant, you still only have a 3% event rate over the 8-year follow-up, excuse me. But as you can see, kind of when we get to, year 5, we drop under 100 total patients. So this was not statistically significant here, but just there were events in the oral anticoagulant group. So antiplatelet versus oral anticoagulation, this is a different study. Oh my gosh, I'm blanking on that. I think this was the Defense PFO trial. And this was the difference between, oh no, this is still the closed trial, excuse me. It's just comparison of antiplatelet and anticoagulation. But see, the event rates were actually relatively low in both groups, N of 3 in the anticoagulant group and N of 7 in the antiplatelet group. So while there's, an absolute number difference, there was not a statistical difference given kind of the low event rates. So they couldn't definitively say or comment upon the safety of an anticoagulation versus antiplatelet. So this is kind of the main randomized control trial that's comparing this. So instead, here is a meta-analysis of patients. Here we have the closed trial up at the top. And these 3 other trials right here, Navigate, PICS, and Respect SUS. These all were subgroup analysis in patients with patent Forman Ovale. So these were not studies dedicated to looking at these 2 groups comparison-wise, but instead had a subgroup analysis of patients with stroke with patent Forman Ovales. So notably, when we do a meta-analysis of these 4 studies, we notice that we trend towards significance, but once again, with that confidence interval crossing 1 with a risk ratio of 0.69. So with those, we still don't have a statistical significance, although we tend to favor anticoagulation. And that's why the AHA guidelines don't specifically recommend or even really discuss the use of DOAC versus antiplatelet. They just give a level of evidence of, a recommendation of 2B in those patients. As kind of, this is our drawn data, but I will kind of talk a little bit later about the SKY guidelines, which talk a little more significantly about this. So kind of next, this is the AHA's kind of flow sheet about discussing PFO. And the reason I want to bring this up here, up at the top is obviously, you need a neurologist and a cardiologist, do all the things to make sure, this wasn't another, an alternative cause that could be treated. And then obviously, if there's another cause, treat the underlying cause. But I really want to kind of zoom in on this, which is this is when we start talking about high risk versus low risk PFO. So in the AHA and ASA guidelines, they specifically mention two features: atrial septal aneurysm or large right to left shunt. So that's when we kind of shift into the high risk PFO closure. And then we'll talk about those anatomical features and some other ones that trials included. The only thing that I want to discuss here, which I'll kind of bring back to later when we talk about the rope score and the SKY guidelines, is there are two potential benefits of closure, that two factors that will reduce the benefit and kind of change your weight in discussing how you should do this. And that is a low rope score, which I'll talk about in a second, and a pre-existing need for anticoagulation. Both of these will make it so that the data would favor PFO closure devices less. So you're more likely to just leave them alone if you have a low rope score or pre-existing need of anticoagulation. So let's talk about these anatomical defects. So a lot of this is because of these two trials, which really went in to define. The closed trial had a subgroup analysis, and once again, the defense PFO trial only included people with high-risk PFOs. So the closed trial defined high-risk PFOs as atrial septal aneurysms, was diagnosed based as the septum primum excursion greater than 10 millimeters on TEE. And then a large shunt was defined by the appearance of more than 30 microbubbles in the left atrium within 3 cardiac cycles of opacification of the right atrium. So this was defined, almost exclusively based on the bubble study within the TEE. So the defense PFO is a little bit different. They do not mention the bubble study or talking about cardiac cycles. Instead, they include the same definition of atrial septal aneurysm. It's not in here, but it was in the supplementary appendix where it was excursion greater than 10 millimeters. They, however, discuss hypermobility, so the phasic septal excursion into the atrium greater than 10 millimeters, so movement of the PFO or the atrial septal aneurysm during septal excursion. And then PFO size was not defined as, this bubble study, but was instead defined as a maximum separation of the septum primum from the secundum of greater than 2 millimeters. So let's see some examples of this. So here are two examples of atrial septal aneurysms that I found from case reports. So here, left atrium, right atrium, and you can see this large excursion of the excuse me, of this aneurysm into the right atrium. That's most definitely over 10 millimeters. And then once again, we look on here on the right side, and it's kind of the same thing. We can see this large excursion into the right atrium. So here instead, I wanted to just kind of show comparison-wise, this is what the defense PFO trial used as a large shunt, which was instead the comparison of the septum primum, septum secundum, and then the maximal, length of this being greater than 2 millimeters. So that's how they defined a large PFO rather than the 30 microbubbles after 3 cardiac cycles. So I like this. This was from a JACC review article that was talking about basically the 4 different groups that were based on PFO size with the septal excursion and atrial septal aneurysm alone. So obviously not including the bubble study there, but up here in the top left, you can see an atrial septal aneurysm with a large PFO based on the size. Here on the top right is the atrial septal aneurysm again, but with a non-large PFO. The bottom left is a large PFO, but with no septal aneurysm. And then last, this bottom right picture is non-large without. So these are all PFOs, but you would consider up here in the top left the highest risk because it has both of these features. And then B and C have one of the features, and D is neither. So I thought this was a nice comparison of all 4 kind of categories here. So then where do we get this data? Obviously, we have the close and defense PFO trial, which are largely the drivers of the statistical significance. But these other earlier trials also included subgroup analyses of high-risk anatomical features. I didn't fully go through each trial, but the definitions of large PFO were slightly different. I believe RESPECT and GORE REDUCE had very similar. So we're seeing that this definitely partially drives our statistical significant outcome, but with really relatively similar profiles here. So, and then below, we can see these low-risk anatomical features in the same kind of initial 4. And we notice here that this is much less positive. Kind of the reason these 2 trials, close and defense PFO, came out are because of these initial 4 trials. So they wanted to really hone in on high-risk PFOs. And we can see this is, not statistically significant at all, and that this crosses 1. So then we can really see why the AHA guidelines give this slide right here is really why they give a 2A recommendation with high-risk features and a 2B recommendation with low-risk features. One thing I do also want to point out is, once again, in close and defense PFO, we see that there were 0 events in 8 years of follow-up in either close or defense closure groups. So pretty impressive there for that in terms of kind of thinking about PFO closure devices. So now that we've kind of walked through anatomical features which would make you more likely to close the PFO, let's talk about those modifiers. That the need for anticoagulation is pretty simple and straightforward, but let's talk about the rope score. So here's the rope score on MD Calc. Really, I thought of it in the similar way that we think of a CHADS VAS score, except it's actually reversed. So you get points for a lack of comorbidities. So history of hypertension, diabetes, previous stroke, smoker, and age, all of these will affect your rope score. So the younger you are and the healthier you are, the higher your rope score. And then you also get a point for documented, really known stroke, so cortical infarct on imaging. So one thing I thought was interesting was, even in MD Calc, when you go to the discussion about the rope score, they say this should not be used to decide which patients undergo closure. And the reason they say this is because we don't have a randomized controlled trial based on high or low rope scores. So, while these are included in the guidelines as helping inform our discussion, they are not enough to really just make that decision alone. So here is kind of the data behind this. This was, there were a couple of other trials that discussed this, but this is the largest. Once again, we don't have any prospective trials. So this is a pooled analysis from the Closure 1, Respect, and PC trial. If you remember, these were all 3 earlier trials. So the Close trial and the Defense PFO trial are not included in this analysis. And I'm sure eventually they will, pool the other 2 more recent to kind of make sure they're up with all of the data. But that low rope score, so remember, low rope score meaning you have high comorbidities and or higher age, showed that there was not a statistical difference in between the recurrent strokes in the device arms and the medical arm. So this was regardless, like I said, there was a subgroup analysis of high-risk PFOs. This does not take into account high-risk versus low PFOs. This is kind of all comers in these groups separated by rope score. But in patients that are older and sicker, they really showed that there was no statistical difference in recurrent strokes between the 2 arms, although there was, an absolute difference here on the risk ratio, the hazard ratio, was 0.82, but, crossed 1 pretty significantly. However, when we talk about high rope score, so younger patients with less comorbidities, we do have significance here. So there's a relative risk, a relative rate, of 0.3 recurrent strokes per 100 person years versus 1.03. And this hazard ratio was 0.3 with statistical significance up to 0.85 in the confidence interval. So included in this, you can see that there were 1,200 patients, so with high rope scores, so a pretty good number of patients in this analysis that led to a pretty good confidence that in these patients with high rope scores that they were better. One thing I forgot to mention a little bit earlier, they defined a cutoff of 7. They didn't really discuss, they briefly just said that the level of comorbidities and age, because you don't just get 1 point for age, it's a kind of a sliding scale. So you can, when you're up to 59, you might get 3. When you're down below 35, I think you get like 3 or 4 points. So it can be weighted pretty heavily on age. So when we crossed 7 was what they decided. So one thing they also mentioned, which I thought was interesting, is when they did individual and then grouped analyses, that this all held the same in each of these trials. So it wasn't just one trial driving the entire statistical significance. This was the same when they did 2 trial analyses and 3 trial analyses. So these results held consistent. Okay, so that's the rope score. So we can use that, those kind of history of hypertension, diabetes, previous stroke, and age, along with the defined clinical imaging to use that in all of these things. So one thing I thought was interesting is we have these guidelines and have these things to help us inform our discussion, but there still is an immense amount of variability. Remember, this is only a 2A with the best selected patient. They still only give it a 2A for a closure device. So what I thought was interesting is there was an observational study done by the AHA, which sent out surveys to stroke neurologists, general neurologists, interventional cardiologists, and cardiologists. And what they did was they asked them whether they would include a closure device in 2 patients. So the first was a young patient with no other risk factors that didn't have any identifiable cause of their stroke. And look at this. So here is in the stroke neurologies and the interventional cardiology, 80 to 90% of these will recommend PFO closure devices. And then that number goes down with general neurologists and general cardiologists, although general cardiologists still kind of favor it pretty significantly. But noticeably, there are still people in these groups that say no. There are people that would not close even the most well-selected patient for a PFO closure device. And then here's another one where they have a patient with low risk factors, but with modifiable estrogen replacement and cigarette smoking in a young patient with no other cause. And already look how low this goes. So over 60% of stroke neurologists would not close that PFO just if you add on estrogen replacement therapy and smoking. So, there is a lot of variability. Notice that would not in the rope score. The reason they did this is because they didn't mention risk features of this, and the estrogen replacement and smoking are not included in the rope score. So these patients, per our guidelines, still have a 2A level of recommendation, and they are not different in terms of just those factors. Cigarette smoking and estrogen replacement are not included in the guidelines. So just with that difference, it shouldn't be a different based on our guidelines alone, but you can see this tremendous variation in these. So with all this, there's still a wide level of variation on who will do what and why. So with that, I thought we should end it with the SKY guidelines for the management of PFOs, because these really are a little more involved in the AHA-ASI guidelines, because they kind of drill down and have a guideline management for PFO alone in patients with stroke. So first, I thought it was important just to include this recommendations for adults without a prior stroke. So this is just patients with incidentally picked up PFOs. So I thought that was important to do as well. So without a prior PFO stroke, and who other embolic etiologies have been excluded. So this is their primary event, the reason why they're coming in. The SKY guidelines suggest PFO closure rather than medical therapy alone. So once again, right here, they even say they have a conditional recommendation with very low certainty of evidence. Noticeably, one thing I thought was interesting about the SKY guidelines as compared to the AHA-ASA guidelines is they don't mention the rope score or high-risk anatomical features in this. As we know, it is for interventional cardiologists, so they're always going to be a little bit bullish on their procedures. But regardless, with this, in patients that are under 60 with non-lacunar strokes, the SKY guidelines are to consider closing it, although to have that risk-benefit discussion. So here is, again, for adults with prior PFO stroke, percutaneous PFO closure versus antiplatelet. So this was just the PFO alone. This was a direct comparison talking about, well, what if we just put them on antiplatelet? So once again, between the ages of 18 and 60 with a prior PFO stroke, recommends closure rather than antiplatelet therapy alone. So this is one of their strongest recommendation. So this is saying this patient has had a recurrent stroke now, and now should just have their PFO closed with a strong recommendation. And once again, they say if you've already had an associated stroke, this is now your second stroke despite antiplatelet therapy, instead of going up on medical therapy, regardless of rope score or regardless of anatomical size, you should be closing that PFO. But also say that using these things are subpopulations who may receive greater benefit, kind of similar to what the AHA guidelines said. And then third recommendation here for PFOs, recommendations for adults with PFO-associated stroke, PFO closure versus anticoagulation therapy. So here between 18 and 60, it's the same population, but anticoagulation versus antiplatelet. This still suggests PFO closure, but once again, going from that strong recommendation with moderate certainty, they go back to conditional and low certainty of evidence, once again remarking that patient anatomy and the rope score may derive populations that have greater benefit. And last, this is kind of where Miss SH fell, so that's kind of how I wanted to close it, is discussion about PFO strokes with other indications for long-term anticoagulation, so the PE in the case of our patient. So with this history of DVT requiring lifelong anticoagulation, which our woman fell under, and a concomitant PFO associated stroke, the SCI guidelines suggest PFO closure plus anticoagulation. So that rather than lifelong anticoagulation alone, once again with a conditional recommendation, but very low, so kind of their lowest level of evidence to suggest this. And then 4.3 here in a patient with a history of PE, so BE rather than DVT. Once again, saying that PFO closure plus anticoagulation with the same sort of very low level of evidence. Notably, some of you are probably remembering going back, her age was 68, and she had a independent of age, so you made her age 60 in the rope score, she had a very low rope score. So because of this, after discussion, she was placed on DOAC and aspirin alone. So if we're kind of thinking back to our case there, she did not undergo a closure device, even with, so if we think about all of these high-risk embolic phenomenon that she had, because of kind of her level, her age and her comorbidities, we went with medical therapy alone. So kind of in conclusion, let's kind of remind ourselves of our learning objectives. So hopefully I've gone over a lot of the primary data of which the AHA and ASA guidelines are derived. And notably, one of the important things that these are all in patients 18 to 60 and with non-lacunar strokes. So even if you have a very healthy 62-year-old with no comorbidities, we really don't have data to support PFO closure in that age group, although, here's where we get into that gray area. So second, PFO closures have been shown to have benefit over antiplatelet/antithrombotic therapy alone. We kind of went through the meta-analysis there. High-risk anatomical features that can help decide who should undergo it are that large atrial septal aneurysm, both defined as an excursion of greater than 10 millimeters, or large shunt. So once again, we have multiple definitions. The gap size, so talking that 2 millimeters between the primum and secundum, and then the amount of bubbles, that 30 of micro bubbles after 3 cardiac cycles. One thing I do want to mention there is kind of focusing in when the AHA and ASA guidelines kind of mention it, they don't say specifically what they're talking about when they say that, but they do say large right to left shunt. So the way I kind of interpret that is that they were putting more favor on the micro bubbles as a size, because having that right to left shunt, you're seeing that with the bubbles, although no definitions in the guidelines themselves. So next, the rope score can attempt to risk stratify patients who are at risk for recurrent strokes with PFOs. So remember that it's basically the lower your score, the higher amount of comorbidities you have, thinking about it as a kind of a Chad's VAS score in reverse, and that these can really help define patients that will derive benefit from PFO closures. And then in patients who need anticoagulation, regardless of PFO closure, SCI currently recommends a risk-benefit discussion regardless of anatomic score or rope score. So in patients that need treatment for PE, while they did overall recommend a PFO closure device, these people will warrant further discussion about whether or not they should benefit. So with that, I'll thank you all for your attention. I know I'm finishing early, but I assume everyone's okay with that. But I'm happy to take any questions. Here are my references. Happy to take questions from anyone.
Thank you, John. Very good. Excellent review. I did not see one thing. I have a comment first, and then a question. My comment, I did not see Dr. Clements logged in here this morning, so I will sort of say what I know he would say. He's not a fan of the term atrial septal aneurysm. He wishes it was a different name, because he's mentioned frequently that it tends to cause significant anxiety for patients, and maybe a lot of people who it shouldn't be causing them that much anxiety, because they see the word aneurysm and get all worried it's going to rupture or something like that. So he likes to use a different term, like highly mobile atrial septum or something along those lines. But I guess just in terms of like real world application.
This is Neil Dickard. One other thing I would just add related to atrial septal aneurysm is, you mentioned the excursion of 10 millimeters or 1 centimeter. The important thing is that's in one direction, right? The ASC guidelines, it's an excursion of 10 millimeters in one direction, or 1.5 if you combine the right and left. And I will say, just on a practical level, I personally find identifying the midpoint nearly impossible in many cases. So I much more often find myself relying on the 1.5 total excursion rather than the 1 centimeter excursion in a single direction, because the midpoint is just tough to define. Just a practical comment.
Yeah, agree. I usually use the 1.5 total excursion, because I agree. It's where the baseline is often nebulous.
It's very difficult to define
on M mode. All right, well, I'll defer. Dr. King has his hand raised, so I'm not going to make Dr. King wait. Dr. King, you have a question?
I do, yeah. John, that was an excellent review. Several things. One, Neil, I agree that those anatomic features probably aren't what really make the decision. But whereas the clinical trials are interesting and clinical trials are informative, and all that, I like to think about the patient and say, how does this patient fit in any of those clinical trials in terms of where they fit? In those clinical trials, are there patients like the one you showed? And I would submit that they're probably vanishing few, if any, that are like that. So what do you think happened? Do you think that there was a paradoxical embolism showering the whole multiple places on the left side? Did that happen from the evidence that you have on this particular patient? Do you believe that this was embolic from that source rather than from undetected atrial fib or something else? What do you think?
Yeah, I think in the end we were pretty confident that was an embolic source, mostly just because of the degree and the kind of the multiple areas of embolic phenomenon kind of all at once. Like, we were kind of thinking the likelihood she has acute limb ischemia, it's a cerebral infarct, a STEMI, and a PE. All from the an AFib source, especially, and part of it was also that PE. So we had both a right-sided and systemic circulation phenomenon all at the same time, which made us favor that. Mm-hmm.
Okay, my second question is, what is your confidence that DVT and pulmonary embolism can be eliminated by the medical therapy that she's on?
Oh, that's probably a trickier question.
Lifetime confidence that you're not going to have another one.
Probably relatively low.
Yeah. Okay. Mm-hmm. So if the chance is that she's going to have another one, even if it's relatively low, whatever that is, and she's my patient, and I'm saying, well, if she has another one, that's bad. She'll have a pulmonary embolus, but maybe we can manage that. But if she has the ability to shower her whole left side with embolic material. And the patient says, well, I really don't want to have the PFO. I'll stick with medical therapy. I would be compelled to sit them down and go through. Why are you opposed to the PFO closure? Because it's invasive. Well, you've had all kind of invasive things already. You've had cerebral angiograms, you've had coronary angiograms, you've had coronary interventional procedure. You've had a lot of things that are much more dangerous than plugging this PFO, which is extraordinarily low risk procedure with a very high chance that you eliminate that as any possibility. So I would just say I would be compelled to recommend PFO closure.
And she's tricky, right? Because she was on therapy, wasn't she, John? When I mean, clearly it was provoked by a broken hip, but she was on therapy for prior.
Yep, she was already on a DOAC. That was kind of the biggest. You're exactly right, Dr. Williams. That was one of the biggest pushes when led to the kind of the longest discussion with I think Dr. Thames, Dr. McDaniel, the neurointerventionalists kind of all together had a lot of discussions about this, and Dr. Kumar as well, because she was pre-existing on a DOAC before any of this. That was kind of the thing that pushed them. But after conversations, I can't remember exactly what the conversation with the patient was like, but after multiple conversations with her and the entire group together, that's why it was eventually just antiplatelet therapy plus DOAC.
All right. We have another raised hand. 102-147. You got your hand up. Fire away.
Stan Sherman. Basically, you were going to say, or I think you had said you were going to say DOAC versus Coumadin, and was there any data on DOAC versus Coumadin? And I'd just like to vote with Spencer on I'd close this thing, but go ahead.
Yeah, there weren't, as far as I could find, there weren't any head-to-head trials of DOAC versus Coumadin. There were earlier trials that included, antiplatelet versus warfarin alone, and that once again, I didn't include them, but they once again favored warfarin, but were not statistically significant. But to my knowledge, I couldn't find any head-to-head trials or even retrospective trials comparing those two.
So she ended up on DOAC plus antiplatelet therapy. Is that right?
Yes, sir.
And everybody had already tried to get her to close it, and that didn't work out.
I don't know how aggressively the recommendation was. I don't think the discussions with Dr. McDaniel and Dr. Kumar and the patient were, you should close this, and then she said no. I think it was more of, these are our two options. As far as I remember, this was back in July, so I'm trying to remember the exact discussions we were having at the time.
Excellent review. Thank you.
Hey, Robbie.
Oh, there he is.
Hey. So that was a great review. Thanks so much. We have to remind ourselves when we're counting bubbles, that's extremely difficult to do. Some of the studies do count the bubbles. They use more than 20, more than 30. You have to remember, it's like slicing through a giant cloud. And whatever you count, it's multiplied. There's a big multiplier there as far as the degree of the shunt. And so you also get a feel for what type of provocation it takes to bring it on. Like, do you really have to cause them to do a heavy duty Valsalva or whatever? But part of that is trying to get that interatrial septum to evert or turn concave toward the left side. If you don't make that happen, then it'll be negative, and can be a false negative. If you have a high left atrial pressure, the bubble stage is going to be negative also. If you have an interatrial septal aneurysm, and I agree with what Robbie said about calling an aneurysm, that creates a lot of cardiology consultations. And the left atrial pressure is high, then that very thin area in the interatrial septum everts toward the right side, and that causes stasis in that area and can be thrombogenic in itself. So that's how an interatrial septal aneurysm can cause a stroke in itself. And if you've been in the echo lab, when Robbie and I have been over here, I've shown this picture of this one. It's like protruding toward the right side with smoke in it. And the patient had an embolus to the arm or something like that. And then sometimes you will ponder over whether or not the atrial septal aneurysm should be the PFO should be closed, and you scratch your head and scratch your head. And the patient will pop up and says, well, I want this thing closed. And we'll take the burden of totally making that decision from your shoulders, as some of our nurses have done in the past when they had TIAs driving home. That was great. Thank you so much.
Steve, you'd vote to close too, wouldn't you, Stan?
Yeah, we're all leaning in the direction of closing nowadays. I mean, I never sounded right.
That polling thing with where you poll people about to give them a case. If you put this case out for neurologists, cardiologists, everybody, I'm pretty sure that this would be a 95% closure vote.
And we're getting better at closing them too, like we are with ASDs.
All right. Well, thank you everybody for tuning in this morning. Hope to see some folks at the holiday party Saturday night. Check your emails, and have a great rest of your day. We'll see you next week.
The preceding program is copyrighted by Emory University.